Hi, I'm Dr. Antonino Secchi, an orthodontist practicing orthodontist from Philadelphia, and I'm a clinical assistant professor at the University of Pennsylvania, and I've been teaching treatment mechanics for almost 8 years at the University of Pennsylvania. I would like to thank Dentsply GAC for inviting me to participate in this webinar to talk about something that is really my passion and is treatment mechanics. I would like to introduce you in this roughly 60 minutes on the CCO system, and I would like to basically start reviewing treatment mechanics. I would like to mention something very important, and is that basically we're going to be talking about mechanics, but I want you to remember that basically every case that you will see in these presentations, there is a diagnosis, a treatment plan, a mechanics, and a patient management. So it's important to remember that, even though I will basically emphasize treatment mechanics. As you can see here, I have a pointer. So when I want to emphasize anything, I'm just going to be moving this green pointer. So CCO, or Complete Clinical Orthodontics, is a system that basically integrates three different technologies that we have and we have had for a long time. The first one is the straight wire appliance that, as we all know, is being with us for more than 40 years, 42 years to be very precise. Also, self-ligating brackets that even though the first system was developed in the 30th, it wasn't until pretty much 15 years ago that they started becoming more popular, and specifically about 2000. And also integrate the heat activated arch wires and the stainless steel arch wires. Interestingly, the stainless steel is being with us for the beginning of our profession, but the heat activated arch wires, they became more popular in the 90s. So how we integrate these three technologies that we have for a long time is going to be basically the core of this system that we will introduce in this presentation. Very important is the levers. As orthodontists, as clinical orthodontics, we want quality, and we want quality with consistency. And I would like to start emphasizing that concept, the concept of consistency in the result. So it's very important for me to emphasize that consistency means that regardless of where you start, the end will be the same. And that means that basically we would like to bring every case that we treat to a very similar and consistent end. And I would like to start showing you some few cases that I have treated over the years. I would like to show you the initial arch wire and the final arch wire and the treatment result. Well, we will see some more cases during the presentation, but I would like to start showing you these few different malocclusions and how we treat it to emphasize consistency. So case number one is basically a class 1 crowding, and you can see that's the first wire when we start treatment. This is the last wire just before we remove the appliances, and a very important concept is this concept of finishing the case with the appliances in place. So you can see here basically is the case after removing the braces. You can see that over here too in this view. And the next case, case number 2, is basically an extraction case where I remove upper first bicuspid and lower second bicuspid, minimum anchorage in the lower, medium to maximum in the upper. You can see the first wire the day we place the braces. And that is the last wire with some fine tuning, and basically this is the case finish. That's another view over here, the frontal view. You can see also the 45-degree view with the arch coordination. So you can see also in this case over here, it's a non-extraction class 2 on the right side, deep bite, and that's the first wires. We upright the molars, we distalize the molars to achieve class 1, we level the occlusal plane. That's the first wire, and this is the last arch wire where the occlusal plane is level, arch are coordinated. Basically, the molars have been distalized on the right side to achieve a class 1. That's the final case after we remove the appliances. Or you can see also a case like this is a full class 2 that I treated with an expander, some class 2 orthopedic treatment, and you can see this is the initial photograph. That's the final arch wire, and you can see over here the final result. So you can see the consistency. The next case is basically just the opposite. It's more like a class 3 malocclusion, where you can see the first wire. We treat this case with some interproximal reduction and class 3 mechanics, specifically on the left side. So that's the first wire. This is the last wire before removing the appliances, and you can see right over here is the final result, achieving the same goals as all the other cases. Or you can see this case number 6, the last one, just few examples. This is an open bite where we have to leave a space in the left side for the implant, and basically this is the first wire. This is just before the appliances were removed, and you can see the next photograph is the case finished with the implant in place and the crown. So the idea of these few cases is just to emphasize the concept of consistency and the concept of, regardless how the malocclusion looks at the beginning, the pattern, the occlusal pattern, has to be the same. And that's a goal that basically we have to achieve during treatment. And basically we will explain some of the few strategies that we use to achieve that. Although this presentation is just the introduction of the mechanics that we use. It's very important to understand, interesting I would say, the clinical, the evolution of the clinical orthodontics. If we understand this, we will see how we have changed over the years. You can see here we start with angle in 1900, and pretty much every 15 to 20 years there is a new movement in clinical orthodontics. Tweed in the 40s, Begg in the 60s, Ricketts in the 70s, Roth in the 80s, Andrews, Alexander, Janelli settling between the 70s and the 80s, McLaughlin, MBT in the 90s, and Damon in 2000. But it's been already almost 15 years, and I think that we're ready for a new movement, a movement that have to integrate basically most of the good concepts that we have learned over the years with the new technologies, with the technologies that we have today, that we understand much better right now, to develop a system that can be applied and where we can achieve consistent quality results in a very efficient and practical fashion. Interesting, every one of these movements is being linked to different appliances. As you can see over here, from 1900, a blank bracket, a single bracket without any information on it, we went to the twin bracket developed by one of the faculties at the University of Pennsylvania, Dr. Barney Swain, in 1954. Then you have the Beck bracket, the Lewis bracket, popularized by Alexander, then the straight wire in 1970, and today in 2012 we have a lot of self-ligating brackets, you can see over here, and I think that there's no question that they came to stay. And right now the number of people using self-ligation have grown a lot, and therefore we need to understand these different appliances, how they work. Also, it's interesting to see the trend in the wires. It's amazing that over 75% of the history of orthodontics is being done with only one wire, stainless steel. But lately, in the last 20-25 years, we have a lot of more arch wires, like the super elastic and heat activated arch wires, that they have changed the way that we practice, and we need to understand how we can integrate those with the appliances that we have today to take advantage of the technology and achieve the results that we all like. I have to give a little bit of an introduction of the history of the straight wire so we understand what we have now, why we modify some of the things that we're using. And I think it's important to emphasize that the straight wire was developed in 1970 by Larry Andrews, was the first tooth specific appliance that has tip, torque and offset for each individual tooth. And that was basically when the prescriptions started becoming popular. He developed this standard prescription where every tooth, as you can see in the table, has a specific torque values, tip values and offset. Interestingly, after about 6 years of practicing with the straight wire, Larry Andrews change some of the brackets values because of problems that he had with extraction cases. As you can see over here, he overcorrect about 12 different brackets to overcome problem of closing spaces when he sliding teeth using round wires, specifically 016 or 018 stainless steel. As you all know, when we close spaces on a round wire, there's some secondary effects, movement that we have. As an example, over here I placed the canine where 4 different degrees of tip. 11 degrees was the standard, and he overcorrect the canine to 13 degrees, 14 degrees, and even 15 degrees. So in cases of maximum anchorage, maximum retraction of the canine in round wires, the canine would basically tip distal and rotate, so he overcorrect the bracket for that reason, and he came out with the Andrews translation bracket, which basically were asking for having a large number of different brackets and a huge inventory, and basically it didn't go well commercially. And it wasn't until the 80s when Dr. Ron Roth basically took one of the Andrews setups and basically he modified some of the values, and he came out with the Roth prescription. And you can see over here that he increased the torque of the upper incisors, increased the tip of the upper canines, increased the torque and offset of the upper molars, reduced the tip of upper and lower premolars and molars, and it was very he was very big on filling the slot. So one of the Roth biggest thing was to fill the slot to express all the values using a 21 by 25 stainless steel arch wires. And because of the overcorrections that he picked, basically many people describe this prescription, as you can see over here, as an extraction prescription. Interesting was the uprighting of the molars and premolars that they built up in the prescription, because as you can see over here, the tip, they reduce the tip of the upper molars, and they reduce the mesial tip of the lower molars and second premolars, and the idea was to upright these teeth as you level and align. As you can see here, most of the malocclusions, they start with a mesial angulation or tip of the crowns, and if you level and align, those tip upright. So that was what many people call at that time build anchorage on it. And this concept was taken from Charlie Tweet, that in 1940, as you all know, he came out with the anchorage preparation, basically through second order bends. He was uprighting the molars to create anchorage before start moving the anterior teeth. So then in the 90s, we have MBT, McLaughlin, Bennett, and Trevisi modified the Roth prescription based on the appliances and the wires that they were using at that time. As you can see over here, they were using conventional twin bracket, lighter forces, and they realized that most of the orthodontists will not fill the slot, and they will use the 19 by 25 stainless steel as the biggest arch wire. And as you know, on an 022 slot, a 19 by 25 stainless steel has about 12 degrees of play, and therefore they removed some overcorrections, and they add other overcorrections based on this play. For instance, over here I just highlight the 17 degree of torque for the central incisors, and the 10 degree of torque for the lateral incisor, etc. So it was based basically on the play that the 19 by 25 stainless steel has on a 022 slot. But right now, after almost 2 decades of the MBT, we're in the 21st century, and self-ligation became, or is becoming, popular. And as you all know, we have active appliances, passive appliances. I don't want to argue about that, passive or active, in this webinar. I just would like to say that I prefer and I use active appliances, and therefore all the cases that you will see and all the mechanics that I will explain is based basically on active self-ligation brackets. Over here I place a photograph that we took at the University of Pennsylvania of an innovation bracket. When you can see basically on the right the design of the slot, and on the left you can see a photograph that I took of one of my patients with a 20 by 20 bioforce inside of the bracket. And it's interesting to mention this design of the slot. You can see here the wall. The base of the slot is 022, and this is the occlusal wall that is basically 028, and the smallest wall on this bracket is the gingival wall that you will see in the next photograph right here. That is basically an 019. You have here a little space where this active clip, or I would say a clip with memory, that if you push the clip out, the clip will try to come back and it will be pushing the wire into the slot. That can be a wire that is bigger than 019, or can be a round wire that is smaller, but if the tooth is rotated, the wire will be acting on the clip, and as the clip goes out, the clip will try to come back and push the wire in. So that is how the clip become active. And it's important to understand how this bracket and wires work in order to appreciate some of the changes that we have done in the values. Here I have a photograph explaining basically how the active clip works and why it's been shown that provides a very good torque expression. To express torque, you basically need to seat the wire in two walls, and you can have a wire that is not filling the slot. However, if the clip, as you can see here, is pushing the corner of the wire and is pushing the wire against this two wall, the wire doesn't have to necessarily fill the slot to be expressing torque. So it's almost like the clip act as the other wall that keeps the wire seated over here. And it's been shown that basically active appliances provide a very good torque in wires that are less in size than basically the 022 slot. I would like to show you this study done by Dr. Nobriga and colleagues, that basically they are evaluating the torque efficiency of two different appliances, an active and a passive self-ligating brackets, all 022 slot, and I will show you specifically the lower second bicuspid. They tested different arch wires on this apparatus that you can see over here on the right. You can see here the bracket is an 022 slot with 22 of lingual torque is the second lower bicuspid, and they tested in different arch wires like the 17 by 25, 18 by 25, 19 by 25, and 21 by 25. It's very interesting to notice that as you can see over here on the innovation bracket on a 19 by 25 stainless steel, you have full expression of torque. So basically you don't have play between the wire and the slot because of the clip, the active clip. This is very interesting because if you use a bracket with overcorrection because of the play, then that overcorrection will be expressed fully on a 19 by 25, and therefore some adjustment has to be done in order to express the values that we really want. So it's very interesting, and therefore over the years we realized that there were some problems with the current versions of the straight wire and self-ligating brackets available. Interesting is to see that there are countless straight wire prescriptions available in the market, and the reason is, the question is why we have so many different setups. Also interesting is to notice that none of the straight wire setup prescriptions was really made to fit an active self-ligation bracket. That's very important because I just mentioned that the way that the arch wire interact with the bracket and is different. Since you have a clip, basically the whole story changes, and basically we need to understand how that clip interact with the arch wires to basically design or the proper mechanics and also the proper values of the bracket. Also, another thing that is very important is that we realize right now that the molar tubes are passive. Interestingly, self-ligation brought these two words to the table: passive and active. Passive and active, we were not talking about passive and active in 1990. We didn't even know what that meant at that time. So these two words, passive and active, are pretty new for us. And basically it is important to realize that tubes have always been passive. There's nothing really pushing the wire against the slot on a tube, and that is very important because we have realized now that there is a significant amount of plate even in large arch wires in the molar tubes, and we know that basically means that we have a lot of lack of control, specifically with torque. Specifically, torque is very difficult to express in tubes. As you can see in this slide over here, with the tubes we can control tip, torque, and basically rotations of the molars. And it's very interesting because as you can see in this photograph right here, another photograph that we took at the University of Pennsylvania, you can see how much space you have in the slot when a 19 by 25 or even a 21 by 25 stainless steel arch wire is in the tubes. So there is a lot of plate, and that play basically is against torque expression. And you can see also in the next photograph, interestingly, we measure different tubes from different manufacturers, and just to give you an example of how much variability on the sizes you can find, you can see here on the left a tube that they're all 022, and you can see this one is the one on the left is 024 by 032. The middle one is 022 by 028. That's about right. The other one is 023, 031. So it's basically there's a lot of variation between the sizes of the tubes. And that variability and the play that you have inside, of course, change the expression that you get. I challenge everybody, every clinician, to go back to their clinic and to grab a big wire, the biggest one that you can find in your office, a 21 by 25, and just put it inside a tube in your hands, and you will be surprised how that tube will slide over that wire. As butter. It's really unbelievable. So you can see that lack of control specifically um, is seen in the second molars. The second molars is a terminal tooth. It's the last tooth of the arch, and basically is the hardest to control. And typically, as you see in these two photographs over here, the lower molars will roll lingually, and the upper molars, they stay labially. Very difficult to torque them um, palatally, and you can see in many situations, after we level, you see the lower second molars, they roll in. You see a difference in the marginal ridge. You think this is the height of the cusp or the height of the bracket, and it's not the height, it's just the lack of torque expression. The same thing in the upper molars, and usually that palatal cusp is always hanging down, and it's very difficult to level the curve of Wilson, and therefore we need to express more torque on those tubes. As you can see over here, they have changed the prescriptions over the years, just to account for that. From Andrews, -9 degrees of palatal torque for the molars. Roth overcorrect that to -14 to trying to level the curve of Wilson for functional reasons, and it wasn't enough. And we modified that with the CCO prescription, and we have a molar tube of -14 and one with -20, specifically for the second molars. As well as the lowers, we upright the molar tubes to -25 and -20 degree of lingual torque for the second molars. By default, we always place the molar tubes in the lower more gingivally than we should, just to avoid contacts with the upper teeth. And the more gingivally we place the tube, the more lingual torque we are expressing, specifically when the labial surface of the molars is very convex. So this is why an overcorrection was really needed. You can see over here, this is one of my cases where I use it for teaching the value of torque expression in the molars. You can see this open bite here. Beside that, this is an adult with small lateral incisors. You can see a little bit of class 3-ish developing, some crowding in the lower, congenitally missing second premolars in the lower arch, and an open bite. And if you see that open bite is due to a primary contact all the way in the back of the left side, because the palatal cusp of the upper second molar is basically touching the labial cusp of the lower second molar. This is what is called a B contact, and that B contact can be corrected many times just by torquing the upper molars in and the lower molar out in order to sit the palatal cusp of the upper molar on the fossa of the lower molar, and therefore close the bite. As you all know, 1 millimeter of difference of the vertical in the back means sometimes 2 or 3 millimeters in the front. And I will show you just how I corrected this case by leveling and aligning and providing the right amount of torque on the molars. So here's the case the day I placed the braces. Bends in the second molars. You can see this zoom of the photograph, where I like to highlight the contact of the second molars, the upper with the lower. So we will not review wire by wire as we usually do in the courses. We will just go from this wire, the first one, to the last wire over here. And when you can see that the bite is closed, the occlusal plane is level, and we have a better overbite overjet and a better intercuspation. So the idea, as you can see here with the finished case, you can see how the bite is closed. You can see here after 1 year post treatment. And basically what I would like to emphasize over here is basically that we went from the upper photograph to the lower photograph, to the open bite, to the bite that is closed, was all due to management of the molars. And in the next photograph you will see how the molars look level. You don't see the palatal cusp of the upper second molars hanging down. The molars are, the curve of Wilson is more level, as well as the lower molars, where you can see that the cusp, the labial cusp of the molars are in one line, and that was achieved through management of the torque. So the torque of the molars that we can express with our appliance is very important, and it helps also to coordinate the arches and achieve sometimes corrections in the vertical plane. And if you can see over here, the proper inclination of maxillary and mandibular molars due to basically proper torque management. Another thing that I would like to bring is the offset. Other prescriptions years before overcorrected the distal offset of the molars. As you can see over here in this photograph, the lower molars have 0-degree offset, and the uppers, they have 10-degree offset, distal offset. That was basically because the mesial buccal cusp of the first and second maxillary molars is more prominent than the distal buccal cusp. Because it's more prominent, the tube has to be wider on the distal port than on the mesial port. How much wider? About 10 degrees. So you don't have to basically put a first order bend to on a wire. So then some other orthodontists over the years, they overcorrect this distal rotation in order to achieve more anchorage. But that anchorage, right now we don't need it, and we will see in just a few more slides why we don't need that anchorage built into the offset of the molars. And basically the offset can actually give you some problems for arch coordination, and we will see now. So therefore we don't like this overcorrection of the offset, and we left our prescription with 0-degree of offset for the lowers and 10-degree of distal offset for the uppers. As you can see here, typical situations that many orthodontists see in a routine basis is how, as you start leveling and aligning, as you can see in the left photograph, you can see that the molars in the lowers, they just rotated distally, and then I have to remove the bend, put the tube more distal in order to rotate the molar mesially and be able to basically align the groove and the molars in a correct relationship. So you see that a lot in the lower molars as well as the upper molars, and that can cause a lot of problems for arch coordination. So you can see over here in this diagram that I try to explain basically how arch coordination can be affected by rotating the molars distally. Now you can do that by placing the tubes in the wrong spot, too mesial, by using too much overcorrection on the molar tubes, or by using auxiliaries such as transpalatal bores, if they're not very well adjusted, they can rotate the molars distal. If you rotate the molars distal like this, you will realize that the wires come out mesial to the buccal port and distal to the lingual port. That will eventually move the premolars out and the second molars in like this, and they will produce a problem with arch coordination. Many times after we level and align, we start seeing that we have an end-on molar relationship on the second molar, and we don't know what's happening, or you see that you lost the coupling, or it's difficult to couple the premolars. And sometimes it's just that the molars are so heavily distal rotated that they're bringing the premolars out. And of course the premolars will not move bodily because the roots, they usually tend to be in the bone, but the crown is the one that's going to sort of tip buccally, and it will look in the arch, in the mouth, it will look like the premolars are not coupling and they lost their relationship. So very important is to have the right offset for the molars. This case over here I used to see how a simple case like this one, that it was a class 1 with crowding, can become a problem if we basically don't manage the offset of the molars. You can see this is starting the case with a no 1/4 centilloy, and suddenly as I start leveling and aligning, the case start opening until basically the bite gets open. I'm just gonna go one slide back so you can appreciate a little bit more this. You can see that now the bite is open and it's touching only on the molars. So that was a problem that I created it by rotating the molars distal too much with these transpalatal bars. I was trying to torque the molars in, and I did adjust the bars with too much distal rotation, and you can see how the molars, the first and second molar in the next photograph, you can see that the first molar is really distal rotated. You can see this huge step that I highlight here with these red lines. You see that a lot in the upper and the second molars, and that is a problem with an excess of offset. That offset will make basically the molars to be touching, specifically the first molar, on this oblique ridge of enamel that you see in blue over here. And then this primary contact will keep the bite open, and basically it will produce a vertical problem. So as you can see over here, what I have to do in this case is to change the bands, to take them out and to place them in the right place, more distal. And also I remove the transpalatal bars to basically re-coordinate the arches, and just by doing this the bite closes. As you can see over here, the mandible outer rotate, the bite close, and basically I finish the case. That's the last arch wire, and this is the they remove the braces with a good intercuspation. You can see here the frontal view. So it's, another thing that is very important to mention is the inclination or torque of the incisors. Many of the mechanics that we use, specifically here in United States, are class 2 mechanics, either class 2 elastics or class 2 correctors, forceps, herbs, etc. Even leveling the curve of P in many cases produce a proclination of the lower incisors, and they tend to upright the upper incisors. So therefore, to have very good torque control of the incisors is very important. And we have changed over the years from the Andrews prescription, the standard, to the Roth, where he increased the torque of the upper teeth, because it's very difficult to achieve proper torque in some of the appliances that they were using at that time. They needed to fill the slot, and losing torque was common, specifically in extraction cases. Then, as we mentioned, MBT increase the torque of the upper and increase the lingual torque of the lower incisors due to play in the arch wires, 19 by 25 stainless steel and the brackets. And we have used them all in self-ligation. And just as a summary, I can tell you that after we tested clinically, we were happy with the results that we achieved with the 12th degree in the upper and -6 in the lower. Remember that torque, specifically in the upper, is fully expressed on a 19 by 25 stainless steel. Also, we modify the canine in the upper. As you can see here in the diagrams, we left the upper canine with 10 degree of mesial tip. We went away from the 13 degrees. That is being proved time after time that it moved the root of the canines to distal, almost touching to the premolars. Another thing that we did with we upright the lower canines from -11 degree of torque to -8, and the reason was because today, as you can see in this photograph, specifically when you have nice arches, upper and lower arches had been basically coordinated. Phase 1, a lot of expansions are being done, and when you have a good upper arch that really match the lower arch, sometimes in the transverse, sometimes it's very difficult to couple, as you can see on the left, and you would like to upright more the canine, or actually the lower, or move the upper canine in a little bit, and you would like to have a relationship more like the one that you see in the right side of the screen. So improve the canine overjet. So we have our prescription of -7 for the upper and -8 for the lowers. There's some options also for different cases. As you can see over here, this is basically the prescription that is available, and there's some few teeth that they have an option, like the lower incisors torque -6 or -1, or the upper canine -7 or 0 degree is another option too for some very particular cases. As you can see over here, this is the full setup with every bracket as it is, with the tubes. And another thing that this photograph brings of this setup is bracket placement. As you can see over here, the goal is to be able to line up every single tube and bracket with an arch wire. And the idea is basically to have all of those brackets in the right place. And I would like to mention really briefly about bracket placement. You can see here that these dots they represent the FA point, which is the middle of the clinical crown. And the idea is that when the teeth are all perfectly aligned in the arch, you have all these dots basically all tied together with a line that it could be basically a wire. And the challenge for the orthodontist is basically to be able to place the bracket on top of this FA point, and so when we are all level and aligned, the case looks almost finished before replacing the appliances. As you can see in this particular case over here, what I would like to emphasize that is a straight wire that goes through all the FA points where the brackets are placed, and basically the case is finished with all the crowns in the ideal position before we remove the appliances, as you can see in the next photograph. Another very important topics that I would like to cover, at least give the introduction to it, is the stages of treatment mechanics. This is really the core of the mechanics in order to have a very efficient and practical way to basically achieve the result. Um, I like to divide the stages in three, as many clinicians do. Stage 1, leveling and aligning. Stage 2, the working stage. And stage 3, the finishing stage. What is really important to emphasize at this point is that every single stage has goals that you need to achieve before going to the next stage. And those goals need to be really clear, and the movement that will happen in one stage are different than the one that will happen in the next stage. And also, it's very important to notice that there's some specific arch wires at each stage that you should be used to facilitate to achieve those goals. Even though we could be talking a long time at each one of the stages, I would like just to briefly emphasize or highlight just a couple of concepts for each one of these stages. So we will start with stage 1, leveling and aligning. Stage 1, leveling and aligning. So as I mentioned, I'm just going to point out a couple of things of each one of these stages. So it's very interesting to see how on a case that need alignment at the very beginning, there are some different forces acting over the teeth. Some people have called this reciprocal anchorage. So in this diagram here, you have the wire engaged in every single tooth. The wire has memory. The wire is going to try to start recovering the arch form, and you can see that there are some forces that they will be acting over here. Very important is to notice that there is space in the arch, and that is diagnosis and treatment planning. Here we're talking about mechanics, but the space needed in the arch is based on the diagnosis and treatment planning. We can gain space by moving teeth forward, by moving teeth out, by extractions, by doing interproximal reduction. So that is part of the diagnosis and treatment plan. In this diagram, I'm just going to show some space. So basically, you can see that here the laterals, they want to come out. As an effect, the central incisors, they would like to come in. As an effect, the canines would like to come in, but because there is space, they will just go back. They will go back because the wire is free to move back through the premolars and to the tubes. And you can see that happening time after time when you start aligning teeth, and then you align without losing anchorage or without protruding teeth. Something very specifically that we see in self-ligation when we allow the wires to move freely on the tubes and on the brackets. Also, when you combine that with the uprighting of the molars, as you can see here, we start with round arch wires that they don't have any torque effect on the incisors or on any tooth. However, they can tip and they can rotate the teeth without any problem. So as you start leveling and aligning, also the molars and premolars, they rotate back, they upright, and many times they move the incisors also back and they upright them. Specifically, I would say in extraction cases. So usually in severe to moderate crowding, I use a 014 centalloy as my first arch wire. Then I go to a 018 centalloy, and I finish this stage with a 20 by 20 Bioforce arch wire. Then I reevaluate bracket position. If I have to change any bracket for big errors, that's the right time to do it, and just keep with the 20 by 20 for one appointment before going to the stage number 2. So as you can see over here in mild crowding, you can go with a 018 centalloy and then go to the 20 by 20 Bioforce. I would like to show you this case as an example of leveling and aligning. You can see here is a class 1 bimaxillary protrusion. Here's the cephalometric numbers, and here is basically the 014 centilloid, and you can see how that wire will go after few months all the way back, and in 3 months you have the canine all the way back, the incisors in a better overbite overjet, the space is reduced, and that was done without any elastic or any extra anchorage, rather than just the wire working on the case. Then after 8 months, I have the 20 by 20 bioforce with the arches level and aligned completely, the space reduced, and we are ready to go to the next step, stage 2 working stage. And of course here is the finished case. Important is to notice the distance between the upper canine and the premolar. See how the wire is getting smaller after the alignment is done. So all the extra wire has to go somewhere, and it usually goes back. And that's the beauty of this system, that as you level and align, the wire goes back. It's easy for the wire to go back than to move teeth up or forward, and therefore you have this basically dental anchorage built into the appliance. Now you have the finished case here. That's after 1.5 years post treatment. And then that's the x-ray before and after. So stage 2, working stage. I would like to emphasize here a couple of things. One is arch coordination. Arch coordination is very important, and that refers to overjet. We have an anterior overjet and we have a posterior overjet, and you see here the arch coordination means we need to achieve a proper overjet from second molar to second molar. As you can see, the upper bracket and tubes are far more buccal than the lowers. That's about 2 to 3 millimeters, and therefore we need to coordinate the wires. It's very important. Every single stainless steel arch wire has to be coordinated. You can see here 2 wires, upper and lower, taken out of the box. They're not coordinated, so the idea is just to coordinate them so the lower wire will be under the upper 2 to 3 millimeters, as you can see in this situation. So every arch wire has to be coordinated. The other very important thing is leveling the occlusal plane. Leveling the occlusal plane means that if the occlusal plane is divergent, like in this case, the end goal is to have the occlusal plane of the upper and the lower parallel, one to each other, like in this diagram. Or if the occlusal planes are convergent in a deep bite case, also they need to end that being parallel, one against the other. So that's very important, and that refers to the concept that paralleling the occlusal plane, the upper and the lower, is a treatment goal that we need to achieve in every single case. No matter how you start, the end has to be the same. So I would like to show a couple of cases like this one here, when we need to coordinate the arches. Is a unilateral crossbite on an adult that it couldn't be corrected surgically, so we camouflage, we coordinate the arches to basically camouflage the transverse dimension and be able to have the upper arch overlap the lower arch. And you can see an open bite. So on this view you can see that the occlusal plane, upper and lower, are not parallel, are divergent. So you can see here that we start with a 0.14 centilloid, and we coordinate the upper arch using a transpalatal bar to move the molars buccally and torque them in order to achieve a good buccal relationship. And basically the leveling and aligning allow us to coordinate the arches. So I'm going to show you how we go from here to here, and in about 12 to 14 months we have the upper and the lower arches coordinated, parallel one to each other, on a 19 by 25, and at this point we can use vertical elastic triangular 316 6 ounces for the upper canine to the lower canine and to the lower premolar. And then basically we finish the case. You can see here the case finished with the arches level, occlusal plane parallel, the upper and the lower, and you can see over here the upper arch is coordinated to have an overjet of about 2 to 3 millimeters over the lower arch. Now it's the opposite. This is a deep bite case with a buccal crossbite of the right side, and the idea was the same. Just to parallel the upper and the lower occlusal plane and coordinate the arches. So you can see here we start with the upper arch in order to create an overjet to be able to basically flatten the lower occlusal plane, basically to level the curve of P. So we went, I'm just gonna drive you from this wire to this one when we have a stainless steel in the upper, and we have everything level and aligned, and we have the lower appliance just built, I mean just placed in. We open the bite with stops, blue composite stops in the molars, just to open enough so the upper teeth will not be touching the lowers. And then we move the lower wire, all the sequence, up to a 19 by 25 stainless steel, and here I have the upper arch level and the lower arch with a reverse curve P. I put the reverse curve P with my hands in the lower arch wire stainless steel, and at the same time I ask the patient to wear a class 2 elastic, short class 2, upper canine, lower second premolar, and you can see that as we do this, the lower curve P, I mean the curve P in the lower arch get flat. And this is how we parallel the occlusal plane, as you can see over here, and then it's more parallel and then more parallel. Then we start closing the spaces, and we are back to where we should be, basically with the upper and the lower occlusal planes parallel, and then we finish the case. You can see here the frontal view too, with the arches coordinated and the occlusal plane parallel. And basically the sequence in non-extraction cases is 19 by 25 as the working arch wire, and that's the arch wire that I place the reverse curve when I need it. I would like to mention that in extraction cases we use a 19 by 25 or 21 by 25 stainless steel with hooks and centaloid coils, and depending on the anchorage requirement we use one wire or the other. I will not talk about in this webinar about management of the anchorage, and we will probably do that in another webinar, but it's something very important, and we have that within our mechanics with the CCO, managing the anchorage, maximum, minimum, or medium anchorage. Finishing stage, the last one, is when we fine-tune the occlusion, when we made those little changes just to have everything looking the way that we like. And usually I use a 21 by 25 stainless steel braided wire. The braided wire is a gray wire. Is a stainless steel made of 8 or 7 filaments, which made the wires to be flexible, so you can actually change bracket positions if you have to, and you still can engage the wire. That little flexibility with vertical elastics allow you to basically settle the occlusion in the buccal segments. I usually check bracket position, and if I have to debone or rebone one bracket or two, I will do it. And this is just a picture of the braided wire that is very good at this stage. I would like to show you a case just to finish this webinar. where we fine-tune the occlusion with the braided wire, so you will have an idea of what we can do. This is as you can see, is a class 2 case with crowding. I treated with extractions of the upper and the lower second premolars, and this is the first wire, and I will drive you all the way from the first wire to the last one. This is when we place the braided wire, and as you can see over here, there were some few problems, specifically two. In the area of the lower incisors, there was a black triangle because the lower left central incisor was inclined. That was bracket position. And also in the lower the lower first premolar was not sag in. So I moved the incisor to the right position, the bracket, and I moved the lower right premolar down and distal, and I asked the patient to wear a couple of very short vertical triangles in the right and in the left, and you can see how in one visit you go from here to here and the bite settles. So we were able to sag that premolar in and basically to close the black triangle by aligning correctly the lower incisor. And that's the finished case. And basically that was the last case, and I would like to thank you all for your kind attention, and I hope that this short overview of our mechanics with the CCO system was of help. Thank you so much.